All right. Hello, everybody, and happy Father's Day. So that's me and my son, Sky, who's 23, and he's one of the main reasons that I hope to live a long and healthy life, because I want to be around to help him become the best possible man he can be, best possible human being he can be. Lately, he doesn't seem to need much help from me, but I still want to be there for him. And I'm wearing a shirt he gave me last Father's Day that says Hawthorne, just like a dad, only way mightier. So I'm Hawthorne, and I'm also the inventor of nanots, a new class of medicine, which treats disease via targeting of soluble factors, soluble meaning dissolved in blood or other fluid of the body. So historically, disease research and drug development has been very cell-centric. Existing drugs are mainly antibodies that target cell surface receptors, or they're small molecules that likewise target cells. However, soluble factors, meaning signals between cells, are often direct mediators of disease and arguably are more relevant targets than cells. Soluble factors and cells form a dynamic system which is dysregulated in disease and aging. And depleting soluble factors can reset a dysregulated system, including dysregulated cells, without targeting the cells. And we're going to show proof of that. The problem is that the existing drug classes are poorly suited for soluble targets, whereas nanots are purpose-built for soluble targets. So how do we do that? Well, nanots are fabricated using biodegradable materials and modular chemistry, which is repeatable, scalable, and safe. There's a core, which is the main structural element. We're currently using coated silica. We're moving toward polymers. Onto that, we attach capture agents that have specific binding affinity for the target we're aiming to deplete. Then we attach a porous shield, which makes the nanots specific to soluble targets and completely inert relative to cells. And finally, we attach a stealth coating just to delay immune recognition until the capture process is complete. It ends up being 150 nanometers across. That's the size of a typical virus. And you inject it like a drug, but it's cleared naturally by macrophages, and it doesn't hurt the macrophages. It's essentially a molecular sponge, or you can think of it as molecular apheresis. And we build it using click chemistry, which was 2022's Nobel Prize. It's a modular chemistry. Although we're preclinical, the platform is already validated and fully extensible. The nanot binding kinetics have been confirmed in multiple rodent models, and those kinetics will not be different in any vertebrate species. You just have to scale the dose to get the same kinetics. Nanots can be rapidly developed against virtually any pathogenic soluble protein, and we've made dozens of them so far against 4 different soluble targets. We've demonstrated that nanots against soluble TNF, the master inflammatory cytokine, shifted mortality in a simple model of cytokine storm. We've demonstrated tumor suppression multiple times. We've demonstrated ultra-rapid prototyping, and also that the shielding on the nanot, which is a key function, works perfectly. In terms of applications, we're looking at a broad range of inflammatory diseases and all solid tumor cancers. The targets are disease-specific soluble factors in blood that drive or enable these conditions. And this is an example of how we approach the problem space. So this is for inflammatory diseases and targets. The x-axis in red above are various inflammatory diseases. The y-axis are the major inflammatory cytokines that drive those conditions. And on the right are suppressive diseases. A suppressive disease is any disease where you have aberrant cells that persist because they secrete immune inhibitors that prevents the immune system from destroying them. All cancers depend on immune inhibitors for their survival. And the main immune inhibitors that we're focused on are listed on the blue y-axis there. And the bottom line here is that a very small number of soluble signals and inhibitors drive or enable a large number of diseases, and we'd argue core mechanisms of aging as well. Now, the nanot chemistry is modular, so changing targets and diseases just requires swapping out the capture agent. So for instance, to deplete soluble TNF, you put in a capture agent against TNF. That will rapidly, fully deplete soluble TNF from circulation and abrogate the etiology of any disease that depends on TNF, of which many do. Or if you want to focus on taking out an immune inhibitor to treat cancer, you just put in a capture agent against, for instance, soluble TNF-R1. It soaks it up from circulation, creating a diffusion sink, which is a well-characterized biophysical phenomenon that induces migration of the target out of the tumor microenvironment, at which point immune cells can access and destroy the tumor. We're also looking at combinations where multiple targets are required to treat the disease. Last year I presented on MS. If you look up that video, I'm not going to present on it today, but there are 2 targets in MS where the latest science indicates that these are the key drivers of MS. One is soluble TNF and one is soluble TNF receptor 1. And our ultimate goal is to treat sepsis, probably the greatest unmet need on the planet, kills more people than all forms of cancer combined. We know the targets. Okay, but we're going to focus first on these 3 targets because of the many diseases that they drive or enable. I think the TNF axis is the most important axis in vertebrate biology. And these are all on the TNF axis. So we're going to do a quick review of what we call the 6 faces of TNF. So TNF, the master inflammatory cytokine, begins life as a membrane cytokine on the surface of an immune cell, pretty much every immune cell. It's cleaved off into a soluble form called sTNF. That ligates the TNF-R1 receptor. There are 2 receptors for TNF. The R1 receptor is an inflammatory one. And focal delivery of soluble TNF is essential for immunity because it's highly toxic. Non-focal release of soluble TNF is characteristic of multiple inflammatory diseases. Membrane TNF ligates the R2 receptor and transduces primarily a suppressive or restorative signal and generally counteracts inflammatory signaling. This is really interesting. The same cytokine transduces 2 oppositional signals. And this is why the TNF inhibiting drugs, which are the largest drug class of all, don't actually work very well because they don't discriminate soluble TNF from membrane TNF, which is what nanots are engineered to do. The 2 receptors can also be cleaved off to form soluble receptors. They don't transduce a signal anymore. They're just decoys for soluble TNF, and they neutralize it very effectively. Every cancer type we've looked at uses soluble TNF receptors to inhibit incoming TNF. So these 3 soluble forms are the targets of the first nanots under development. So we already know that sTNFR depletion is very powerful because there's dramatic clinical data on the treatment of late-stage metastatic cancer via depletion of sTNFRs by pheresis. Now, nanots are a better way of doing this in every respect, but it's still great to have human predicate data on this target depletion. So there's a clinic in Germany where our CTO and I went back and forth for several years. They treat cancer. Actually, the clinic's shut down now. The inventor of this tech had a stroke. But for 12 years, they were up and running, treating late-stage metastatic cancer patients, basically terminal, as a monotherapy, depleting sTNFRs. All other molecules went back into the patient body, no drugs, no radiation. And they documented a response of 60% ORR, overall response rate, and 24% CR, which is complete response, in a patient population where no response at all would be expected. This is an unheard of level of efficacy. A typical investigational drug would be 10%, 20% would kind of be the asymptote. Compare that with Keytruda when it was in phase 1 in 2015. Keytruda documented just 16% ORR and a 6% CR, and it hasn't really done much better than that since. And yet, it's the best-selling drug of all time. In 2024, the sales were $24 billion. Okay, so last time I presented on this, my friend Matthew Schultz said I really needed to put in more support for sTNFRs because it's just an obvious target to us. We're steeped in it, but a lot of people have never heard of it. There's a lot of data on this target, even though it's obscure. So I actually did a whole diligence study on that clinic on behalf of an investment group before I invented nanots. So I have all the patient data. This has been redacted of personal information. But we know the sTNFR levels before and after treatment. They're significantly elevated. And we also can compare that with the basal level in health. And we also know that the treatment routinely depletes these targets to below their levels in health, and that consistently leads to tumor regression. We also, part of our diligence study, we raised $1 million, did a diligence study. We hired Tim Triesch, who's an oncological pathologist, and he did mRNA analysis of tumors of the same type treated in that clinic, and he found that TNFR1, and he did R2 as well, mRNA levels are 2 to 4 times higher on tumors than normal tissue of the same type. And there's the normal level. And this is a log 2 scale, so it's 2 to 4 times higher. Okay, and he said in his report, these values are as high as I have seen for common genes. All these tumors express both receptors at very respectable levels, implying they are valid therapeutic targets. There's also a bunch of publications. You have to kind of look for them, but they're rock solid. And they document that soluble TNF receptors are functional, they block TNF bioactivity, that patients with high levels have very poor prognoses, and that if you take the STNFRs out, you get great regression. What's particularly interesting is there's a subset of these publications that talk about the role of STNFRs in aging. For instance, Hasegawa in 2000 said STNFRs were increased in sera from the elderly. This may contribute to the susceptibility of the elderly to infectious and neoplastic diseases. And that makes sense, because if you have a potent immune inhibitor rising with age, of course your immune competence is going to go down, and it's going to lead to every kind of disease. And interestingly, the late Judy Campisi, who I knew when I was entrepreneur in residence at the Buck, she documented, in her papers on the SASP, she documented high levels of STNFRs in the SASP. Well, what are they doing there? They're almost certainly protecting senescent cells against immune-mediated destruction, just as they protect tumors from immune-mediated destruction. So this is potentially a senolytic. So if STNFRs are such a great target, why haven't they been drugged? And the answer is they're an undruggable target. A drug against STNFRs would also bind and block membrane TNF receptors, which are essential for immunity. Now, nanots can deplete STNFRs and not disturb membrane TNF receptors. They're blazingly fast. Nanots can deplete soluble targets typically by greater than 95% in less than 5 minutes versus pheresis, which takes much longer and doesn't do as well. So we made nanots against mouse STNFRs and tested them in a mouse model of triple-negative breast cancer, which is refractory to pretty much everything. And we documented 5 times the level of metastasis-free survivors compared with a pair of cohorts, including the mouse equivalent of Keytruda. So nanots against STNFRs induce tumoricidal immunity in metastatic TNBC. And we have a lot of transcriptomic data supporting this result. And we're moving this forward in collaboration with MGH for human studies under Keith Flaherty, who's a legendary developer of cancer immunotherapies. Okay, let's talk about rheumatoid arthritis, or RA. So we're developing a nanot against soluble TNF, the cytokine, not the inhibitor, not the receptor, for patients for whom TNF inhibiting drugs no longer work. So quick review, there's the incidence normally treated with these 5 TNF inhibitors, a very imperfect drug class. All of these drugs carry black box warning labels about reduction of immune competence, leading to runaway infections, even cancers. But it's still the largest drug class of all. This year it's projected to hit $45 billion, and huge unmet need in patients who have loss of response, which we can address. So I'm going to walk through the advantages of nanots over TNF inhibiting drugs for RA and related inflammatory diseases. So first of all, nanots against soluble TNF irreversibly clear soluble TNF. The drugs actually stabilize and generate a reservoir of soluble TNF. So STNF is known to be elevated systemically and to drive RA and other inflammatory diseases. We know that nanots can rapidly deplete STNF from circulation within minutes, and then they themselves and their cargo are cleared by macrophage phagocytosis. So when you're dealing with an inflammatory disease, endogenous suppressive signaling is good, and you want to preserve it. So these suppressive cell types, including Treg cells, myeloid-derived suppressor cells, you want to support them. Unfortunately, the TNF inhibiting drugs interfere with suppressive signaling. So when you have a mTNF-bearing immune cell, TNF inhibiting drugs are going to bind to that membrane TNF and block its ligation of the membrane TNF-R2 on the surface of the cell membrane. That's bad. But nanots are shielded. They won't interfere with membrane TNF. They're specific for soluble TNF. So that signaling between mTNF and mTNF-R2 on a suppressive cell will get through, and suppressive signaling will be maintained. Only inflammatory signaling will be abrogated. We also know that nanots against soluble TNF, we're confident it won't lead to ADAs and loss of response. And the reason is, what drives loss of response is that B cells encounter the TNF inhibiting drug and treat it like an antigen and generate anti-drug antibodies against it. But because of the shielding on nanots, B cells can't interrogate the capture agent. They can't build any intelligence about how we're capturing these targets, and they can't generate anti-drug antibodies against it. So there shouldn't be any loss of response. And we're getting ready to test that, but we're pretty confident. Okay, so Now here's one of the main points, and it's a little tricky to explain, so we did some new graphics. Nanots against soluble TNF should not reduce immune competence the way the drugs do. So, again, nanots are shielded, so they won't interfere with mTNF on mTNF-bearing cells. Why is that important? Because NK cells are activated and proliferate based on an mTNF signal through their R2 receptor. And NK cells are the foundational cell type of innate immunity. And I love how those little red things pop out upon ligation, like the fangs of a vampire. So that NK cell is now armed and dangerous. Now, nanots are engineered not to extravasate. They only operate in circulation. But of course, an NK cell will extravasate to the aberrant cell, release soluble TNF, and destroy that transformed cell group. TNF-inhibiting drugs, they will saturate tissue, and right at the point where an NK cell, if it happens to be competent, delivers soluble TNF, it will be intercepted by the TNF-inhibiting drug and won't get through to do its job. So nanots against soluble TNF fix the issues with existing TNFIs and create new treatment options. And this is just to show that we've already made nanots against soluble TNF, tested them in vitro and in vivo. Okay, so this is the pipeline of products I just showed you, and I'm running low on time, so I'm going to keep moving. But I want to talk about another target on the inflammatory side, soluble IL-6R. Soluble IL-6R may just be the coolest of all inflammatory targets. We know that IL-6 is centrally involved in all of these pathologic conditions, and they all fall under trans signaling. We need to deconvolute IL-6 signaling because there's really two main forms of it. There's trans signaling, which is pro-inflammatory and pretty much always bad, and it's active in aging. Several presenters at this conference have talked about the role of IL-6 in aging and the challenge of deconvoluting IL-6 signal pathway. Because there's also classic signaling, which does all of these positive things in the body. It's generally reparative and restorative. How do we understand this? And the answer is two separate cell groups are transducing these two signal types. So hepatocytes and immune cells have an IL-6 receptor on their surface, as well as two glycoproteins called GP130. Whereas all other cell types have no transmembrane IL-6 receptors, they just have the GP130s. In classic signaling, the IL-6 cytokine binds to IL-6 receptor, it draws in the GP130s, and that transduces this positive signal. But it works differently on the trans side because there's no receptor, but there is high levels of soluble IL-6 receptor in circulation, and that rises with different pathologies, and particularly acute inflammation. So what happens is IL-6 binds the soluble IL-6 receptor, which then is bound to these two GP130s, and even though there's no transmembrane receptor, the GP130s do the trans signaling. Okay, so there are drugs against IL-6. Tocilizumab is the main one, and tocilizumab targets the IL-6 receptor. And it hits the IL-6 receptor on the trans side in terms of soluble IL-6R, and it interrupts trans signaling, which is good, but it also interrupts classic signaling by binding to the membrane receptor, which is bad. There's another drug called siltuximab, which doesn't target the receptor, it targets the cytokine itself, and that interrupts trans signaling, which is good, but it also interrupts classic signaling. It has the same problem, just binding a different target. So our approach is really quite simple. We're just going to deplete soluble IL-6R. We can take it to pretty much near zero if we wish. And once that's gone, trans signaling is abrogated. But again, back to the shielding of the nanot, it won't interfere with transmembrane IL-6 receptors. So classic signaling will still get through. So that adds that cool target to that pipeline. I want to talk about one more thing, which is another oncology target that we're doing with Mayo Clinic. This is soluble PD-L1. It's just the soluble form of membrane PD-L1, which is a very well-known oncology target, tumor-generated immune inhibitor. So I reported last year that we've been collaborating with this group, and they have a humanized mouse model of TNBC. We made nanots against human soluble PD-L1, turned it over to Mayo, and they demonstrated profound tumor suppression. And this is what that graph looks like. And it shows that soluble target depletion is powerful, we already knew that, and that SPDL1 depletion in particular is specifically efficacious. But since then, Mayo has presented a paper at SITSE a few months ago, and it goes into more detail, and I'm going to share an update from that paper. So what they showed is that nanots actually induced a remodeling of the tumor microenvironment. Regulatory T cells, which are pro-tumor, were significantly reduced in the nanot group, and effector T cells, which are anti-tumor, were significantly elevated. And there's the ratio. And when you dig in further and do immunophenotyping of the CD8 positive T cells, you find out that in that population, the subpopulation of exhausted CD8 T cells, which aren't going to do you any good in the future, went way down, whereas the population of your next generation of T cells, which are the stem cell-like CD8 T cells, was significantly elevated. All of this points toward an anti-tumor remodeling of the tumor microenvironment. And this remodeling was achieved solely by depletion of soluble targets. No drugs, nothing else, just taking something out of blood. So we plan an expanded toolkit of nanots for treating sepsis, and each new nanot in this set can also treat specific diseases. All right, so I'm going to skip through that. And we already know that nanots are very safe. We've seen no mortality or morbidity in rodent studies, even at 100 times our planned dosing. The FDA knows what we're doing. They have a framework for it. And our CDO COO, Curtis Rugg, has taken multiple drugs through the regulatory process, including nanoparticles. We own this space. We invented it, and we have 34 granted patents covering pretty much every kind of design. Lovely team. Our CTO, John, is here, so feel free to talk to him if you're interested in learning more. And for those of you who are considering investment in nanotics, don't be that guy. So thank you very much, and I am open to Q&A as well.
That's a great cartoon. Okay, thanks, Lou. Wonderful talk as always. Wonderful progress as always. It's a delight to see such an innovative technology doing so well, and not just in the lab, but also in the clinic. It's wonderful. So, questions? All right.
Great talk, Lou. How adaptable is your platform to other targets? Can you pick up basically any soluble molecule that you would find beneficial?
Yeah, pretty much. As long as we can generate a capture agent against it, and antibody engineering is very sophisticated. You know, you can pretty much do protein engineering against anything. We're using nanobodies in the current upcoming generation. We have a whole qualification process. It has to be worth the trouble, you know, in terms of the diseases we would treat. Concentration can't be over a certain level, but that's huge, like hundreds of thousands of picograms per ml. So it's a very broad range of possible targets.
One more.
Hi, Lou. It's a great talk as always. And it was just something that struck me when I was hearing you talk. So you're now using these nanotics to be able to reawaken the immune response in tumor cells that are cloaking the immune response. But have you thought about using it for something like the papillomavirus? So viruses that go into our cells and dismantle the DNA repair response and the immune response and sit there, causing loads of havoc. And eventually, so the HPV, for example, is going to cause so many cervical cancers. And one of the reasons it's so good is because it can cloak itself. Have you thought about using that for clearing those type of long, latent cancers that are integrated into the genome?
Yeah. So viruses persist in a hostile immunologic environment because they too secrete immune inhibitors. And in some cases, they replicate endogenous immune inhibitors like IL-10. They might make their own version of something very much like IL-10. Our view of viruses and how to approach that whole space is to look at how viruses kill. Viruses, pretty much all viruses, when they kill by inducing cytokine storm. So we're going to just sort of ignore the virus itself and develop treatments for cytokine storm. We know the molecules. It's TNF-alpha, IL-1 beta, and IL-6. That's really forms the nucleus of a cytokine storm. You take those out, you can save millions of people, even while you're developing a vaccine against the next pandemic, for instance.
All right, thanks, Lou.
Thank you.